Saima, I like that rhyme. Saima Sakari. She's a faculty member at VCU, Division of Cardiology, and she does a lot of work in the Cardiovascular Disease Fellowship Program there, and that's designed as a comprehensive training for fellows in both clinical and academic cardiac settings. That particular program is a blend of clinical rotations and research opportunities, preparing fellows for careers in various cardiology fields. So I'm very, very interested in what she's going to say about women's health in the heart tonight, and anything else that you want to add to that. We are most appreciative to have you. I welcome her to our meeting.
Good evening, everyone.
Good evening. Good evening.
So I have a few slides. I have a few things I was going to go through. I'm very happy to make this much more of a conversation, especially since there's not very many of us. Please feel free to stop me whenever you like, if you have any questions. So I am, as was mentioned, I'm the women's heart expert at VCU, so I'm the lead cardiologist at our Women's Cardiovascular Care Clinic. I also have a very special place in my heart for cardio-obstetric patients. So those are women who have had children and due to pregnancy have had heart-related complications, who want to become pregnant but have heart disease that may complicate that, or who develop cardiovascular disease during their pregnancy. Oh, let's see if I have left. Okay, we are apparently getting going. So a few quick facts that we're going to go through while I'm here today, many of which I'm hoping you guys have already heard of, some of which you might not have, which is very fair, and we will go through them a little bit. So first of all, I hope that everybody knows that cardiovascular disease is actually the leading cause of death for women. It kills more women than all of cancer combined. The risk for women accelerates in their midlife, especially after menopause. And so there used to be this idea that, oh, well, heart disease is a man's disease. No, it's not. It's everyone's disease. Heart disease affects women through all stages of life, right? Your beginning of your risk starts when you are young, when you are your children or your grandchildren's age, where you're starting to talk about healthy habits, exercise, diet, what is your relationship with exercising and going to the doctor and doing what you have to do from a preventative point of view. As women enter young adulthood, you add in factors like high blood pressure, diabetes, smoking, habits that you ideally want to avoid. At this point, there's also an increased amount of stress. It's where you also see a lot of women who start to enter their childbearing years, and pregnancy, as you will hear me say later on, is a stress test, and it will expose a lot of underlying cardiovascular risk for women, and it will also lead to risk that will then affect them for the rest of their lives. Women, as they then go through midlife and are entering the premenopausal transition period, the loss of estrogen and the fluctuating hormones can increase your cardiovascular risk in ways that we're still really working to understand and are actively looking into. Post-menopause, the lack of estrogen leads to a lot of metabolic changes in how women carry weight and how women are prone to have things like hypertension and high cholesterol, all of which increases their risk, along with the lack of protective benefits from estrogen that most women have had up until that point. And then lastly, when you get into older adulthood, you have the diseases that become more prevalent at that point in time. So valvular disease like aortic stenosis, heart rhythms like atrial fibrillation, and then of course coronary artery disease and stiffening of the heart that can lead to heart failure. So nearly 1 in 2 women have a risk factor for cardiovascular disease. Women, as I like to tell all of my patients, are weird, and I say this being a woman, so nobody should be offended. We don't present with I have an elephant on my chest, I'm having a heart attack, I've got to go to the emergency room. I've had women tell me everything from, I just had this horrible heartburn and it wouldn't go away, and that is you having a massive heart attack. I'm looking at the women in the room, that's you having a heart attack. If you're saying, I've just been so tired and I don't know what it is, I can't shake it, that could have been your equivalent of having had a heart attack instead of chest pain. Sore throat is one I've heard about. I have not seen a woman who's just had sore throat and she's been having a heart attack. Jaw pain, much more common in women. Cold sweats, much more common in women. Dizziness is a presentation for massive heart attacks, as well as back pain and pain between your shoulders. So things that you don't normally think about and we don't normally advertise as being what you're having when you're having a heart attack is what happens to us. some women can actually, they can develop high blood pressure. Women can develop gestational diabetes at this time, and all of these things can combine to let them have preterm births or low-risk babies, or low-weight babies, all of which are actually risks for their own cardiovascular disease in the future. I tell my patients that if I were to put you on a stress test or put you on a treadmill, you're on the treadmill maybe 10, 15 minutes, right? Pregnancy is running a marathon about once every 2 weeks for 10 months. This, I think, is very important for everyone in this room because you will have, yeah?
Can you speak a little louder?
Yeah, of course. So for everybody in this room, this is very important, okay? You will have a daughter, a granddaughter, a friend, an aunt, a sister, or yourself who will have had one of these, what we call adverse pregnancy outcomes. If you had high blood pressure in pregnancy, if you had diabetes in pregnancy, if you had preeclampsia, if you have PCOS or endometriosis, all of these things increase your cardiovascular risk, and you need to tell them to your doctor because we can't treat what we don't know exists. So I can't, as a cardiologist, modify your risk the best of my ability if you don't tell me that this has happened to you. And a lot of times, women in particular will say, well, that was just part of my pregnancy. No, that wasn't just a part of pregnancy. That is like pregnancy plus. You gotta tell everybody about the plus, okay? So, I've had so many women when I put up this slide afterwards, they're like, you're really making me not enjoy being a woman so much. So menopause, while very natural, is not a fantastic period in a woman's life, both from a symptom point of view, but also what that transition does to us, right? Your cardiovascular risk increases. Your blood pressure has a chance to increase. Your cholesterol stops working the way that it should. You gain weight, but the weight isn't just normal weight gain. It's very hard to get rid of. It's all in your abdominal area, and it actually acts as a secondary organ. We call it visceral adiposity, which means it's fat that surrounds your internal organs. It's not close to the skin like what you have before menopause. And that fat actually acts like an organ and increases inflammation in your body, making you more prone to developing heart disease. The lack of estrogen causes your blood vessels to be less elastic, making you more prone to developing high blood pressure. Your cholesterol, your good cholesterol, stops clearing the bad cholesterol as well. Your bad cholesterol becomes smaller and more likely to cause heart problems. Your bones become more brittle, which is not a heart problem, but exercise is, and if you can't exercise because you've osteoporosis, that plays a role. And it can affect how you sleep and your circadian rhythm, which is also going to have negative impacts on your heart health. Unfortunately, in addition to all of these risks, the calculators we use for everyone else, or for men, don't actually take into account a woman's true risk. If you look at the biggest calculators we use right now, which would be either a score called the ASCVD, which was put out by the American Heart Association many years ago, or a newer score called the PREVENT score, which has also been put out by the American Heart Association, and that one's newer. They take into account things like what is your age, what is your gender, what is your blood pressure, what is your renal function, do you have diabetes, are you a smoker, what is your cholesterol. They don't include a lot of the things we just talked about. They don't say anything about, did you go through menopause? Did you have preeclampsia? Did you have gestational diabetes? Did you have breast cancer and therefore went into menopause surgically much earlier than you should have? Do you have that visceral adiposity that we talked about? What does your LPA, which is a new marker that we look at now, what does that look like? Do you have disease in the small vessels of your heart? These calculators don't account for any of that. They also are very good at looking at risk, but at a very specific period of time. They are not good at looking at risk in a period of time where things are drastically changing and quickly changing, like they are through menopause. And that's why women who, when you put the numbers into this calculator, look like they're low risk, actually they're not. We just haven't found a way yet to quantify the risk that is elevated, but that is there. So if I ask most of my fellows, what do they think of, and we're gonna see if this works. Oh, yeah, okay. What do they think of when they think of the anatomy of the heart? They're gonna. No, it's not gonna work up there. They're gonna tell me that they think it looks more like this. They're gonna tell me that when we talk about the big vessels of the heart, and we say you're having a heart attack and I need to stent something, that's this, okay? But when you cut your finger, you don't see a giant blood vessel that's just bleeding everywhere, right? You see blood, but you don't see any blood vessels. That's because you see this gobbledygook, right? That's because all of the blood vessels in your body divide and divide and divide and divide and divide until you get to blood vessels that are really 1 cell thick. Because 1 cell is the only amount small enough where you can then transfer nutrients and oxygen and remove waste, which is the whole reason for the circulatory system. So your heart, just like everywhere else in your body, has what we call a microcirculation, right? Macrocirculation, all the big vessels, I can see them when I can't see, I can put a stent in them. Microcirculation, the things I can't see, but that we know are there. The things I can't stent, the things that can still get disease, okay? Women, I bring this up because women are known for having something now we know called microvascular disease. We get disease in the small ones, and men don't get it as much. The disease in the small vessels acts differently. It can last, the pain can last longer. It doesn't have the same pressure feeling that, like we talked about, that men get. Your stress test can be normal, and it's still there. That's because this, the big disease, is a blockage. It's an anatomic problem. You have something that I need to push through to get blood back to where it's supposed to go. The small vessels, that is a physiology problem. You are having trouble dilating or you are constricting when you're not supposed to. So when you tell yourself, I need to climb this flight of stairs now, your body says, okay, we're gonna climb this flight of stairs. I need more oxygen, I need more blood. And your heart says, okay, well so do I, because I'm a muscle like any other. And to make that happen, these small vessels dilate. They get big, or bigger when you're talking about 1 cell wide, right? But 80% of the change in blood flow within the muscle of the heart comes from those small blood vessels. Only 5% comes from these big ones. So when you have a problem with the small blood vessels, you're gonna feel pain. You're gonna not be able to do things that you want to be able to do. And this is much more common in women, and this is something we treat with medication, yes.
Is there a way to image that?
Yes and no. Not in a way like this, because I'm not gonna be able to see dilation and constriction on a picture like this. We can look at stress test imaging of certain kinds, like MRI and PET stress, and say, okay, overall, looking at your heart at rest and looking at it at stress, does the overall, what we call coronary flow reserve, or the amount of blood flow reserve that you have, does it change? And if it goes down, that's a positive test. But that is, again, still an evolving field, because as, oh, I don't have that picture. Oh, I do have that picture here. There are multiple subtypes of disease you can have. So you can have pain without ischemia, which is a no-bet. You can have ischemia, where you're gonna have a little bit of a positive stress test, you're gonna go to the hospital, and you're gonna have some elevated biomarkers, and they're all types of coronary microvascular disease. And then you divide that down, and you say, well, I can have problems with spasm of the small vessels. I can have spasm of like the small and big vessels. I can have increased resistance or constriction of the small vessels, and I can have trouble dilating, like I said. But women, because again, we are fun and special and weird, you can also have half of this and a little bit of that and a little bit of that, which makes everybody different, which means there's no standard, well, everybody gets these 5 drugs. It doesn't work that way, unfortunately. It also means that finding one test to diagnose everything also doesn't work, because you're trying to diagnose subtly different things. And so the diagnosis process for this disease is multi-step. It starts out with ruling out disease in the big vessels, which in and of itself can take 1 or 2 or 3 tests, depending on who's doing your testing. And then you get an imaging study or 2 to to look at the small vessels. And then sometimes we even need to do an invasive catheterization testing to kind of further narrow what exactly is happening. So why are we special? Why does this happen in women? So that is because physically, for one thing, we are smaller. So our blood vessels are smaller, which makes us more prone to depending on that dilation and that lack of constriction in those small vessels. We just need that more. We are more affected by something called endothelial dysfunction, which basically means the inner lining of those blood vessels, when that doesn't work properly, we're more affected than men are. Hormones play a huge role in this, which is why CMD becomes more prevalent in perimenopause and at the end of menopause. And it's because estrogen helps produce something called nitric oxide, which helps with the dilation. So without it, you've lost a helper. And then your blood vessels are more stiff, so it's like a double whammy. Things that are traditional risk factors for heart disease, diabetes, high blood pressure, high cholesterol, they actually affect women worse. And I'm gonna talk about that. Women are more likely to have autoimmune and inflammatory disorders which drive heart disease. And women are uniquely able to have adverse pregnancy outcomes like we talked about, like preeclampsia and gestational diabetes, that can, even though they happen at a young age, they increase a woman's risk of having cardiovascular disease starting in the decade after giving birth. And they can be underlying in the background until she's older and causing damage that we just can't see. So, why is heart disease undiagnosed in women? Well, it's a combination of a lot of the things we talked about, right? Women present differently. And so now we're shedding a lot of light on this, and there's the Go Red for Women's movement, which this year their slogan is red doesn't mean stop, red means go, which I thought was very good. But there's not enough awareness about women being different, which is now changing. There's unfortunately a lot of bias when a woman comes in and she says, I'm having chest pain or I'm not feeling well, but the tests look normal. There's a lot of, well, I think you're just stressed. I think it's just anxiety. I think that it's just, you're fine. I've had so many women tell me that, yeah, the doctors told me that I'm fine, but I don't feel fine. Yeah.
I've talked to a lot of doctors regarding that, and probably the most important word they say, for women, you have to advocate for yourself and tell the doctor, I know something is wrong, it's not stress, and I want the test to see what's going on so that you can diagnose it correctly and give me the proper medical treatment. So advocating is really important for women.
It's huge, but I think unfortunately part of the problem is sometimes there's that power dynamic, right? Of, well, I'm just me, and you're the doctor, and you're telling me that it's fine, and you've done all the tests, and the tests all say that it's fine. So I wouldn't even know what do I ask for? How do I say no, it's not fine, right? Women are victims of something called a diagnostic testing gap. So they are less likely to get the testing that they need for a lot of the reasons we just talked about. Also, unfortunately, it is much, and so I'm looking at all the women in the room, if you're offered the opportunity to be in a research study, please say yes. Because women are drastically underrepresented in all of the research, right? So a lot of what we use to apply to how we treat women comes from how we treat men. Because that's who we've studied, that's who's in the studies. And so when the treatment doesn't work exactly, part of that is ours as a medical institution for not having looked at it. But part of it also comes from women don't sign up for studies. And so in order to increase the ways in which we are treated and managed, we have to also take action and be part of the studies that help decide those things, that show the differences between men and women. Some scary facts. women are 50% more likely to be diagnosed late or not at all after they've had a heart attack. And men are about equivalently amount more likely to receive timely diagnosis and treatment. And when it comes to the heart, time is muscle. So the woman who didn't get diagnosed for 2 weeks and then shows up because she can't breathe, it's too late for us to save that muscle. That muscle is gone. It is dead and I can't get it back. Because we underdiagnose women, women are more advanced at the time of their eventual diagnosis. They have a higher risk of complications and death. They are hospitalized more frequently and eventually require more procedures. And we're not doing a good job at preventing their heart disease and reducing their risk factors when we can. So I said before that the traditional risk factors affect women more. So we know that we tell everybody, stop smoking, right? Smoking has a stronger effect on the cardiovascular systems of women than it does on men. And it is worse after menopause. Diabetes, the risk of heart disease if you're diabetic in women is 3 to 5 times higher than that of men. High blood pressure is one of the longest lasting and greatest impact risk factors that women can address. Men too, but women.
Would that be due to a women's smaller blood vessels? That's why
blood
the risk factors affect them more strongly than men?
No, it actually has to do with how women respond to certain things. So a lot of it has to do with inflammation. Women are in general more prone to autoimmune disease and more susceptible to the negative effects of inflammation.
So
And
more physiology.
More physiology than anatomy.
Okay.
Yeah. So high blood pressure is one of the most, yes.
So have they done any studies where the women who are on birth control through menopause, is there less risk for heart attack for that?
So, about 30 years ago or so, maybe give or take a couple years, there was this huge study. It was called the Women's Heart Initiative. And they've been watching the progression of estrogen, right? In about the 1970s, maybe before that, you're stretching my knowledge of when it came out. We first learned that you could get estrogen from horse urine. They called it Premarin. And they started giving Premarin to everyone because they were like, oh, it's the fountain of youth. Women will look good, they'll feel great, their skin looks better, it'll be fantastic. And then everybody was getting it and they realized, oh, hang on, wait. If we're giving all these women estrogen, actually, if they have a uterus, we're giving them uterine cancer. So everybody said, oh, stop. And so they did more research and they said, but if you give it with progesterone, it's fine. You don't increase the risk of uterine cancer. So again, fountain of youth, estrogen sales went through the roof. And then Women's Heart Initiative came out and said, but wait, actually, these women are at increased risk of heart disease. They're at increased risk of blood clots. They're at increased risk of breast cancer. They're at increased risk of all of these things, which is completely opposite to what we think should happen, right? If I'm standing here and I'm telling you women go through menopause and it makes them higher risk and estrogen is good for their blood pressure and estrogen is good for their cholesterol, you would think that, well, if I give them estrogen when they lose their own estrogen, that it'll be great. You'd think, well, maybe we should give men estrogen, right? No, it doesn't work that way. And so overnight estrogen prescriptions stopped. And we are now looking at that data 20 years later and we're saying, okay, hang on. The data that we're looking at, you're looking at such a huge spectrum of women. You're looking at women who are very young to women who are very old. You're looking at women who are started on menopause replacement therapy within a couple years of menopause. And you're looking at women who are started decades after menopause. And you're looking at women who had heart disease, and you're looking at women who didn't. And two separate groups emerged, and it led to something that we now call the timing hypothesis, which means that if you are within 10 years of menopause, plus minus other risk factors, right? Everybody's decision is a little individualized, that you can have estrogen safely, but not to reduce the risk of heart disease. to reduce or treat what we call vasomotor symptoms of menopause. So women who complain of the hot flashes and the sleeplessness and the mood swings, those things, okay? The women who are older, who got estrogen more than 10 years after menopause, they didn't do as well. And it's because we learned that if you already have that time to build up heart disease, adding estrogen back in destabilizes that disease. So now everyone says, well, what do we do? The FDA actually earlier last year, earlier last year in about November, they came out with this decree that they were gonna take, there used to be something called a black box label on all estrogen containing products. It's a warning label that the FDA puts in big black boxes for high risk medications. And it said, should not be given to women, can increase the risk of cardiovascular disease, among other things. And so they decided, we're gonna take that off of all estrogen containing products, right? The thought initially had been that when it comes to vaginal estrogen, which is safe for women no matter their heart disease risk, because it doesn't get systemically absorbed, that warning should come off, because that was confusing, and we know that was wrong now. But for everything else, we don't know. And so now we're trying to figure out, well, how do you do such a huge study on women who don't want to get involved in a study that is going to have to be decades, right? Because you're talking about heart disease doesn't develop overnight, so you've got to start a study now and study somebody from when she's 40 to when she's 70. And it's got to be huge. And you've got to organize it, and you've got to find people to run it, you've got to get women to sign up for it, and you've got to get the NIH to pay for it, which right now is difficult. There were some studies that were happening with some of the leftover data from this Women Heart Initiative, but unfortunately there's been some funding issues, and so we don't know if we're going to get that longer term data. But it would be fantastic, and I'm hoping that during the time of my career it will be a study that I'll get to recruit patients into, because it's a question we need to answer. Sorry, we took a little bit of a detour. So autoimmune disease, more common in women, menopause and hormonal changes cause all sorts of problems. Pregnancy is a risk factor and a risk enhancer. So I say this because I don't want to scare my pregnant patients, right? Preeclampsia doesn't give you heart disease, okay? What we tell people is that it exposes a risk that was already there. So bodies are amazing. They compensate and compensate and compensate until one day they can't, right? So for these young women who are getting pregnant and they are under all of the stress of increased volume and increased body needs, and they're trying to grow a human, and they're running a marathon, and they're doing all these things, in addition to living their daily lives, the pregnancy, it exposes that they had some subclinical cardiovascular risk there, and that risk manifests itself as gestational hypertension, as low weight baby, as preterm birth. And therefore it exposes risk that was already there. So women should not be afraid to get pregnant. Pregnancy is not going to give them an increased risk of heart disease. It's risk we just was always there, we just didn't know. I like this picture. I got this from Instagram actually. So this is statistics from the United Kingdom, which if you get to know me, you will see my husband is from the United Kingdom and trained in medicine there, and so we have an interesting mix in our house of the UK and the US. What we tell people here is a little different than what we tell people there. Here, oh, this is the wrong picture. I'm sorry. There's a picture just like this that talks about 80% of cardiovascular disease is preventable, right? In the UK, their picture says 90%. But here, 80% of cardiovascular disease is preventable. 90% of the disease that causes strokes is preventable. I tell people that my goal is I would like to be out of a job, right? It's not gonna happen in my lifetime. Unless something drastically amazing happens, it's not gonna happen in my lifetime. But because it's so preventable, it is important to teach the appropriate habits early. If you have heart disease and problems, treat them early. Treat your diabetes, control your blood pressure, know what your numbers are so that if you have high cholesterol, that you're managing that you're teaching your children how to exercise and eat well and do all of the right things, that you're seeing your doctor, that you're telling them about what is actually going on, and that you advocate for yourself, as Joe said. That is really my last, I'm pretty sure that is my last slide. I'm happy to answer any questions, if anybody has any.
I know that at VCU Health, they have classes for first-time pregnancies for the couples to come in up on Main 6. And I wonder if they touch on any of this, just to be able to look for in those classes, or would that be too
We don't,
scary?
because moms have told us it's scary. I think that pregnancy is terrifying, and I say this as somebody who has 2 little kids. Pregnancy is terrifying, right? You don't know what is happening or why it's happening and everything, especially if it's your first time. Is it supposed to be this way? Should I call the doctor? Should I not call the doctor? If you add in, well, you might develop high blood pressure, and then you might have increased risk of having heart disease, and you could develop coronary artery disease 10 years after you have this baby. It's a lot.
So like
And it
much
doesn't-
overload.
And it doesn't apply to everybody, right? We are talking about a percentage, but it is not the majority by any means. That percentage is increasing as women are getting older and women are naturally having more of these risk factors going into pregnancy, as the population is getting more obese, as we're becoming more aware of the disease that you can have in pregnancy, and then also as our patients who have congenital heart disease are able to live into the age where they can have a pregnancy and then can carry a pregnancy. And so the subset is getting bigger, but it's still by no means the majority at all.
Best way to lower the blood pressure.
Take your medication. So what I tell everybody is, first of all, exercise is really good for a healthy heart, right? And the American Heart Association talks about 150 minutes of moderate intensity aerobic exercise a week. That's a lot of exercise, okay? I can't get to that much exercise, and one of my philosophies is that while I will tell you what the AHA says, I also tell my patients what I do, because I think you have to be real, right? So I make it to a boot camp class about 3, if my husband's really pushing me, maybe 4 times a week. I will tell my patients, if you can give me 10 minutes 3 days a week, that is a great start. I would much rather you get those 30 minutes a week, and then the next time you see me in a couple months, I say, hey, why don't you double it? And build it up over time, than have you try to go for 150 minutes and fail. Because if you fail, you're gonna be less likely to try it again. And our research shows that every minute that you get closer to that 150, you just have more and more benefit, right? The next thing is salt. Salt is a huge risk factor, right? And salt hides in a lot of places. Soft serve ice cream has a lot of salt, if you believe that. Deli meats, canned soup, frozen food, all of those things. Now that advice only works for some people, because we are actually learning that there are 2 types of blood pressure. There is salt responding blood pressure and people who don't respond to salt. So they might have high blood pressure even if they eat no salt at all, okay? After that, when you've addressed weight loss and you've addressed risk factors like, do you have sleep apnea? Are you a smoker? Have we checked to make sure you don't have any diseases with your kidneys that could be causing high blood pressure? Then it really is, and I go back to it, take your medication, okay? High blood pressure is the risk factor that we can modify the most. It gives you the biggest bang for your buck, right? Your body's not meant to live with a certain level of blood pressure. It is hard on your kidneys, it is hard on your heart, it is hard on the arteries in your eyes, it is hard on your brain, it is hard on everywhere, okay? And unfortunately, a lot of those systems play together. So if you damage your kidneys because you have high blood pressure, that's gonna negatively affect your heart, you're gonna go into a heart failure. If you have high blood pressure that's bad enough to damage your kidneys, you're going to have damaged the vessels in your eyes. And you will have already had effects of stroke on your brain, okay? I have women as early as their 20s who are on blood pressure. Because if I can put them on blood pressure medication and control that blood pressure when they are 20, that is 7 decades of time that I have bought that person, where I'm reducing their risk, right? Take your medication. Anything else?
Any other questions? Okay.
Is it most
talk
of
to
the,
her personally.
a contributing factor to women also is the fact they ignore most of the symptoms because they are not chest pain, it's minor things, it may be some pain in the arm 1 minute and it goes away and.
I don't think that women intentionally mean to ignore themselves.
Right.
I think we do, but but I don't think we mean to do it. I hear a lot of, it was happening, but my kids had soccer practice and my husband needed this and I had to do this for work and I had to clean the house and this and that, and it just went by. And that was a couple months ago and then it went away, so I just let it go, right?
Okay.
I think that we are really good at, your husband said he's not feeling good, you gotta go to the doctor. I will make you go to the doctor. Your child has a fever, well, they've gotta get better, right? My parent has a problem, I've gotta get that taken care of. And in that, we neglect ourselves. And so I think that it is more that piece than it is that we are aware and just ignoring. Thank you all.
Thank you.
Thank you.
so much.
Okay, I'm going to, I learned a lot, and, I'll be able to talk more intelligently to women that I visit in the hospital now as a result of your presentation. And to remind you that you were with us this evening, I'd like to present to you this little token of our
Thank you.
appreciation for you
I love
giving your
that.
time to us tonight, so that every time that you use that, you can
I
think
will
of us.
think of you all, absolutely.
Yes.
Thank you so much.
Thank you, we appreciate it. And do have some snacks before you leave.
Appreciate
I
that.
know you worked all day and then you came here, so, you know.
If I hadn't promised my daughter that I would have an ice cream with her before she went to bed, then I would have.
We understand that.
My 3-year-old will be rather upset if I didn't.
Yeah. Well, that ends the meeting, we don't, yes.
I would just like to apologize for the small crowd tonight. I know, 4 different people that, are not here because of health reasons, but,
okay.
this is an unusually small crowd, but thank you for coming.
Please, don't worry, not at all.
So we have lots of food for you, so